right? So we didn't go through that yesterday, but we'll go through it when we get into a different block, or we get into a different section. Okay? But you guys did go through rock, paper, scissors, right?
Yes.
Is that rock, paper, scissors? Is that radial, median, and ulnar? Yes. Okay, so we've been through that. And then what's left? Flexor tendons? Don't worry. That's going to be one of the subjects. That's going to be the nerves of this block, right? Flexor tendon injuries. They're more complicated than you think. So we will dive deep into that, and I will give you practice questions. Hook of the hamate. Well, that's just an anatomical feature of the hamate. So guess what? Does it appear to be a hook on radiographic imaging? Yes. Okay, so hook of the hamate is just one characteristic of that bone, and we'll talk about that pathology when we get there. Okay, so don't worry about that either. And then radial artery and ulnar artery. God help you if you don't know what those are by now. Okay, so we understand the radial artery is on which side? Thank you for not saying lateral. Okay, so yes, radial and ulnar is on the ulnar side. And what is that test that we do? Where we compress one side and see for a collateral blood flow return. What's it called? Allen's test. Okay. So it's thrown into my my talk as well, just because it's extremity work. It's really not something we necessarily discuss. But if you want to go through it during the lab, let me know. Okay. Are we good? Okay. So do I owe you anything from yesterday? Does anybody disagree that I owe you anything from yesterday? Okay. Again, yesterday was meant to be kind of a primer. Okay, so don't think to yourself, oh, now I got to know all this. We'll get more into it. Okay. All right. So pathology. So upper extremities, specifically shoulder. We're going to talk about some pathologies. Okay. Chromioclavicular injuries. Yesterday again, we discussed a chromioclavicular joint. We discussed how it's a joint that can have instability. So we'll get into that. And those disease conditions that can exist. Burners and brachial plexus injuries. You guys are all experts now on cervical radiculopathy, correct? So you understand what cervical radiculopathy is versus cervical spondylosis. So now when we start talking about brachial plexus injuries and we start having neurologic deficits, you're going to know the difference, okay? And we'll get into that. Frozen shoulder, okay, that's basically can't lift your shoulder up or away from your body. We'll get into that. Impingement syndrome, we talked yesterday about how if you impinge things under the acromion, you can have pain, correct? But you can also have rotator cuff pathology. So we'll discuss the special test for that. And then what's left? Rotator cuff injuries, okay? So AC joint injuries, or AC injuries, okay? Very commonly they're called shoulder separations. I actually don't like that term, okay? Because if you have lower classifications of AC joint injuries, then they're not actually separated, so it's a misnomer. Okay, but that is a common term that's used, so you have to know that. Okay, they result from a fall onto the lateral tip of the shoulder. So it's basically from a direct blow, a direct fall onto the shoulder. Very commonly, you'll see that in bike accidents. So someone goes over the handlebars, ends up flying through the air, lands directly onto the point of their shoulder. Okay. And football injuries, very common in football injuries, super common. So is it important in orthopedics to get a good history and a good sense of the mechanism of injury? Yes, and this is why. Because again, if they say that they were tackled and landed directly onto the crown of their shoulder or to the lateral aspect of the shoulder, and now they're complaining about superior shoulder pain, should AC injury be in your differential? Well, absolutely 100%. We talked about that yesterday, okay? Are they ligamentous injuries? Yes, because we talked yesterday that there's different ligaments. Okay, so if you look on the screen here, we have all these different ligaments that support the stability of this joint. Okay, so since you have those ligaments, do you think you have degrees of varying tears, right? Whether they be partial or complete, of even individual ligaments? Yes, that's what we'll get into with the classification system. Okay. So that's important, to understand that. So, and there's 6 different types. As you can see, there's bold gold on these slides, so I've done some magic on these. Okay, these are different than maybe a couple semesters ago. So this sheet, or this chart, I should say, still exists, but I think the way it's represented here on the screen is a little bit better to assimilate. Okay, Now, how are you going to keep this straight in your head? Okay? I understand that when you're in certain courses like infectious disease or pharm, you just memorize the chart, right? And that's it. And then when the test comes about, you take that blank piece of paper and you regurgitate it onto that piece of paper, and then you reference it and take the test. Right? Is that helpful in clinical practice? Not necessarily. So I try to give you a way to remember this. But basically, 1 through 3, right? So type 1 to type 3 tends to be something you can potentially manage at the clinic level. Types 4 or more is ortho. So if you want to drop the R and the E and say mo, right? But 4 or mo is ortho. Okay? So that's when there's really no decision point. You have clearly a 4 or more type AC joint injury, right? Those are operative 100%. You see that chart, right? Where it says surgery there on the right? Okay, on the bottom there, those last 3. Is that 4, 5, and 6? Yes. So that's how you remember it. But of course, just to throw a monkey wrench into it, we'll talk about when type 3s might sometimes be operative, but those are subjective. So, but as a relative, as an absolute indication, if you have 4 or more, it's ortho. Okay? So you notice how 3, when it says not operative, is a little star. That star basically means that it's controversial. Okay? We'll get into that. All right? So if you're going to take anything away from this chart, right? Understand that when you're talking about the CC distance, what are we talking about there? That's the corticoclavicular distance. So yesterday when we went through anatomy, we understand that this is what bone? Corticoid, right? And what's this bone up top? Okay, so is that the distance between those two? Yes. So that's a measurement of those on a radiogram. Okay? Makes sense? So that's where they get these percentages from. Okay? And how do you know what's normal?
The other side.
Compared to the other side, correct? So even though we talked yesterday about how you can get AC joint imaging, do we sometimes get a chest x-ray so on one plate you see both sides?
Sure.
Sometimes we do. You can think of it as like an off-label use, right? But at ortho, we do it commonly, okay? But just so you understand, if you run into that in clinical practice, that's a lot of times why we do it. Okay, just to compare both sides at the same time. Make sense? Okay? Because remember we talked yesterday about how if you position the beam in a certain orientation, so more cycloid or more caudal, you'll see a different appearance of the clavicle on the plate. We talked about that, right? So it can be difficult if you have 2 different versions of what's supposedly the same X-ray, and you're trying to compare those 2 sides. Does that make sense? But if someone's standing tall and they're showing a chest X-ray, they tend to be in the same general orientation. Make sense? There's one X-ray, correct? Does that concept make sense to you guys? Okay. All right. So not that that's something you need to understand for a test, but just understand when you're measuring those percentages, look at the ranges. A type 3 is 25 to 100%. That's a huge range, right? So we'll talk a little bit more about how it's really not the percentages when it comes to a type 3, it's what the person does for a living. Anybody who's had me in, God help you, right? In Clincor as your instructor, I tell you, you gotta know what someone does for a living. We're military, we're active duty, right? And I told you guys last block too, ask the person, what do you do for a living? Because if you're right-handed, it's a right-sided AC injury, and they have a high-demand job, do you think they can tolerate an injury that looks like this type 3 here? All right, look at that type 3 there. Does that look like it might hurt?
A little bit.
Does it look like there might be some instability there? All right, so you saying, well, everybody who's a type 3 doesn't get surgery may not be realistic. Makes sense? But 4 or more is ortho, right? And look at the type 4. The type 4 sounds terrible, right? Posterior dislocation, that means it's the clavicle is somewhere behind the scapula. That's not good, right? And look at a type 5, right? Doesn't don't really say too much, but it's greater than 100%. Do you think that that deformity is going to be significant? You're going to be able to see that from across the parking lot. Okay? And then a type 6, which some say is uniform, is an inferior dislocation. So that thing is dislocated and down. Right? So that's going to look weird because you'll want to have elevation of the clavicle. You'll just have what looks like a huge depression where the clavicle is actually stuck down below something. It's inferior. Okay? So that's a bad day. You got to go in there, you got to get it out of whatever it's stuck in, and you got to fixate it hopefully where it goes, right? Make sense? Okay. Any questions about this chart? This chart, every block so far, every semester so far, has frustrated people because you're like, how am I going to remember this? If you just take the principles that I just told you, just keep it in general. You guys have taken the test by me already, right? You understand? I'm not going to ask you something that's like just out of left field, way tricky, way complicated. I will tell you straight out. You kind of agree?
Yeah, pressure kind of matters.
All right, fair enough. But just keep it real, as my son would say. Right? Because I'll try to keep it real too. Okay? So if it's clearly bad, the vignette will tell you it's clearly bad and that it needs surgery. Okay? So what kind of clinical symptoms are they going to have? Well, they're going to have trouble taking their arm and putting it over their head, especially, but greater than 90 degrees, right? Pain with lifting the arms, that's also known as abduction. Okay, so you can have abduction. Is this abduction or is this forward flexion?
Forward flexion.
Okay, good. So we understand the difference, right? Forward flexion is this, right? And abduction is this, right? So are you still abducting? Yes, right? I'm not German. But just I want to make sure we understand the same terminology. When you're reading these scenarios and you raise your hand during a test and say, are you doing forward flexion? I go look at you like, what does the question say? Because I mean what the question says, right? I'm not trying to be tricky again. I'll make fun of it. Okay? So, you see that deformity there? Don't read the words, don't look at the circle. Just imagine if you saw that. Does that look abnormal? So would you document that as abnormal, an obvious deformity? 100%, right? And this could be somebody that just injured themselves, or as I encountered with Misawa, everyone's a professional skier when they get orders to miss out. They all become professional skiers until first time they go down the mountain on a snowboard, and they've never done it before in their life, and they come back looking like this. Right? They say, my shoulder hurts. I say, I bet it does. Right? There's some ligament. Does that look like a ligament might be torn there? Yeah. But in generality, okay, what I want you to get to with this picture, and I changed this, is that when you look at that and you see that, that's called a piano key sign. Everybody knows what a piano key is, right? Has anybody here never seen a piano before? You know that some of the keys are black and some of the keys are white, right? Unless you have to fix twice. But I'm just saying that you would agree that when you depress a key, it goes down, and when you let it go, it goes up, right? So you can imagine that this is the acromioclavicular joint, right? So maybe if you look at the acromion as one key and the clavicle as another, the clavicle key is elevated. Does that make sense? Okay? So the fact that it's elevated and it's resting in that position like this, that's called a piano key sign. Okay? That's what you're describing as the deformity. Okay? What is a piano key test? You push down on it and it goes down. Right? So that's the test. So don't get those two confused. And I think you guys learned piano key test, right? In clinic skills. Someone told me last block that they learned it in clinic skills. It might have been one of the instructors who were trying to be helpful walking around, but really throw a monkey wrench in it, right? That's being recorded. Okay. But anyways, so just understand there's a difference between the sign and the test, right? So the sign is what you see here. The test is when you actually push down on the key and it moves. Make sense? Okay? You think if you were to push on the clavicle or just maintain pressure on the clavicle and have them shrug his shoulders, that the deformity might reduce itself? Yes. Acutely, maybe. But if it's chronic, you think it might scar in and look just like that? Right? So in that case, the sign will still be present, but the test may not may not go. Does that concept make sense? Okay, I just want to make sure, okay? So obvious deformity with type 3 and 6 again, because if we go back to our chart, type 3 is 25 to 100%, correct? I mean, that's a huge variance, okay? So, but with type 1, is it normal? Yeah. Is the CC distance normal?
Yeah.
Right? Okay, so with a type 1, would you see this?
No.
No. Okay, so again, if you see somebody, I say this because you get x-ray reports, right? The x-ray report will say that there's suspicion for an AC joint injury, okay? But you as a student relations are going to look at the patient and you won't see this. They'll have pain there, because the slide says about pain there, right? Would they have pain with any of these? Yes. Right, but you won't see a deformity, okay? So with type 4 and type 5 though, if we go back to this chart, right? Type 4 is a posterior dislocation, and a type 6 is an inferior dislocation, right? Whether you'll be able to reduce the deformity with shoulder elevation, with them shrugging their shoulders essentially? No, right? Because it's the clavicle is entrapped somewhere. Okay, makes sense? That's all this slide is saying. That's it. That's all it's saying. It's not meant to be tricky. It's just expanding upon those concepts a little bit more. Any questions about this? Spent a lot of time on these slides, huh? Maybe key in on that. Okay. All right. Okay. So special tests. What are we going to go through when we get to left? So with the special test, cross-body test. Okay. What do you guys know the cross-body test as? Otherwise. Old man warm up. That sounds accurate. Okay, especially last Thursday. But basically, it's sometimes called a cross-arm test, and it's also sometimes called a scarf test. Have I ever called it a scarf test? Heck no. But I guess if you did this, and don't make fun of me for it, but if you did this and thought it was a scarf, right, that's why it's called a scarf test. Because your arm is scarfing on it, I don't know what it means. But just so you know, that's the same test, okay? So if you see that, it's AKA, okay? What, you probably never heard of an AC shear test though, right? Okay, so everybody has pain with an AC joint injury, but when you shear the AC joint like it's described in that picture, see this picture here? Does that look like you're kind of going back and forth and trying to see if they have instability, not just superiorly, right, because you got that elevation, but also anterior to posterior? That's what you're testing. You're testing to see if they have instability anterior to posterior, right? And will they have pain? Sure. But the AC shear test is not necessarily just for pain. Again, clarifying what tests are for, every test is not positive just for pain. Does that make sense? Okay? All right, so when you document these tests, you're going to write there the patient did have pain. That's fine, I'll accept that. But you're going to say that you also had translation from anterior to posterior with an AC shear test. Make sense? Okay? He's doing it. He's doing that. All right, so active compression test. All right, so active compression test. What do we know that is? What's that? Is that what you're doing? Okay. I didn't want to call you out, but I did. Okay, so active compression test. That is called an O'Brien's test. Okay, you guys see that on the right-hand side there? Okay, if you had to describe that test, is that how you would describe it to somebody? The answer is after this block, yes. Because if you're going to get a test, might it describe it that way? Yes. So what active? Why is it called an active compression test? Anybody clue in on that? Because you're actively compressing, right? Very used to Lieutenant Bishop. That's good. That's why he's lieutenant, right? So I wasn't that way, but we did happen. But so what you're doing is you're actively compressing. Do you think that the act of putting your arm a little bit inwards from midline, or making the push or any of that stuff is as important as having them do maximal internal rotation and having maximum compression? Or do you think all of it's important? All of it's important, right? So I say that because you want to have the arm, right? Forward flexion, thumb down, but not just thumb down, not a little bit of this. You want to have maximum thumb down, if not further. That's active compression. Everybody do it. You feel that tightness inside your shoulder?
Ow.
You feel it? Doesn't feel it, does it? And then come in to the midline about 15 degrees. And then you have them push against your hand, right? And then you have them reverse with thumb up. So you're taking away that active compression, correct? And then you have them go against you again, forcefully, and see whether they have pain with thumb down and thumb up, or both, right? Yes, sir.
Is there a difference between thumb up versus full extension?
Or what?
Thumb,
He's going to use a word.
or thumb up versus palm up?
Oh, yes, very good. I was going to get to that. Because every semester I have somebody tell me that isn't the speeds test just an active compression test? What's the answer, guys? No, it's not. What plane is and this is not picking on you, Mr. Trent. What plane is the speeds test done in? Just this, right? There's no inwards to midline, correct? And there's no rotation component which is causing compression. Good to go? Okay, so those are two different tests. So again, when you see a test being described, make sure you understand which test is being described. But getting back to the O'Briens, and we'll get back to the speeds test. Are you okay with that for now?
It's just a discrepancy with the photo.
What's that?
The photo describes a maximum external rotation. So I was wondering, there's just two ways of doing it.
Oh, I see what you're saying. That's okay. Yeah, he's talking about, so basically the big thing about it is the active compression, but when you're going thumbs up, can you also go thumbs out, where you're just having palms up, but you're also midline, 15 degrees, and they're pushing against you, or going forward flexion basically, right? Yes, those are the same thing. But the biggest component of this is taking away that active compression. Because I will tell you this, and this is the way it's taught. Thank you for clarifying. That's a good point. The biggest thing about the active compression test is that if the patient has pain with a thumb down or with maximal active compression, but no pain with thumbs up, is that a positive finding for, let's say, a labral tear? Yes. Now, if they have pain with thumbs down and thumbs up, is that suggestive of a labral tear? No, right? Can they have pain with any of that and just getting into that position, but they describe the pain as not being more anterior or deep in the subacromial space, and therefore it becomes AC joint pain? Yes. Okay, so I'll introduce this concept early. When it comes to AC joint pathology, they can have pain with any of these tests, right? But again, what makes a positive active compression test is the fact that they have pain with maximal active compression that improves with taking that active compression away, and either being with thumbs up or going palms up, but still being medial to the midline, right? So 15 degrees in, and still going against active forward flexion. Not just being palms up and doing a skates test. Make sense? Don't get those two things confused. Hopefully I did a better job that time. Good? Okay. All right, good. Make sense? Because again, pain is not a positive finding. Good to go? Any questions about that? Okay. All right. Is that how you guys were taught? Yes. Okay. So I was being too dramatic. All right. Yes, ma'am. So with crossbody, I will tell you this. So with the crossbody test, what is, her question was, is it important if the arm is bent? You mean if you go across body and then bend the arm as well? Is that what you're saying? No, I don't know that that really matters, right? As long as you're going maximally across the body. Yeah, I'm not sure that matters. But I will tell you this, when it comes to, and this is something that you'll see in the video even, and I know, if you have nondescript tattoos and you want to volunteer for my videos, I gotta reshoot these videos. Okay? You know what tattoos I'm talking about. Alright, so anyways, so when we're talking about the crossbody test, is that an active test or is that a passive test? In other words, are you doing the test on somebody or is the patient doing it? You're doing it, right? If you ask somebody with shoulder pathology, they have pain, right? And to do that maneuver on their own, are you going to get a good effort? No. So again, this is a passive test. You're going to do it, okay? Now sit on that. All right. Any questions about these three tests? This is a completely different slide. I changed this to make sure we get into it a little bit today. Get on the same page, and we practice it correctly. Okay? Make sense? Okay. Of course it does. All right. So imaging, bilateral weighted AP of the shoulder. Are they going to be normal for type 1? Yes. Are they going to have pain there? Yes. Are they going to have a positive canopy sign? No. Are they going to have a positive AC shear test? Only for pain, not for anterior posterior translation. Make sense? That's why you document the test as such. Good to go? Okay. But again, that's still pain, correct? But there's no instability from the anterior posterior plane as is being tested in that picture there. Good to go? Okay. And axillary lateral will show posterior displacement, potentially for one of the variants that we talked about before. So again, are you just going to get AP views? No. Are you just going to get lateral Y views? No. Are you going to get lateral axillary views too? Yes. So why are you getting a 4-view series of a shoulder when you're like, I looked at the AP and it looks normal? Because again, not only are you testing for these things on physical exam, but you're also searching for these indications on radiographic images, right? So you get a complete series of the shoulder every time. Every time. And which view did we talk about yesterday? It's really good for looking for anterior and posterior dislocations. The Y view. Okay? So there you go. So I will tell you this. If you had to take one thing away from me today from this lecture, right, because we're taking a lot of time with this, but trust me, it'll become relevant. If you had to get one view of a shoulder, right? I'll take it a step over. If you could only get 2 views of a shoulder, right? You know, only 2 good views, right? Because you can shoot X-rays till the cows come home, but you're just making up views, right? You're not getting an actual AP or a true AP, etc. But if you had to get 2 views, remember how I told you that you guys learned, right, in radiology, orthogonal views, non-united views? If you only get 2 views, you get an AP and you get a Y view. Because the AP, you can see everything that's going on from at least in front of the patient, right? And you can also see any kind of distracting injuries, any elevation of the clavicle, okay? And with the Y view, you can see if there's anterior posterior translation. Make sense? But whenever possible, get 4 views, okay? Get all the views. Make sense? You're not reading the patient for no reason. You're looking for pathology. Good to go? Okay. Oh, I'm sorry. MRI, concern for other injuries. Okay, so is there supposed to be, you see that distance there? Do you think I added this on this picture? The answer is yes. Always, right? So I added that there. So you guys would be like, what the heck is the CC distance? That's it. That's the clavicle, and there's the coracoid, and the tips of the arrows are either, right? And then the distance is that. Does that look different than this side? Yes. So that's how you decide what the percentage is. Okay? So usually the radiologist will tell you. They will say there is a relative distance of 40% CC increased distance compared to the contralateral unaffected side, etc. Okay? So that's how you use that data. Remember that chart I told you about? All right? Do you think I have that chart memorized? The answer in that one is yes. But that's just because when it comes to this is good pimp material, right? You guys know what pimping is, right? Pimping ain't easy, right? We get pimped all the time. So I know that one. But I'm just telling you, if you don't remember, you just look it up. Is it helpful in type 3? No, because it's 25 to 100%. So do you think you're going to ask the patient, what do you do for a living? Yes. Do that before you call workup. You'll save yourself a lot of pimping. Okay? Reverse outcomes disease, if you do nothing about it, no scar in that position. Can I tell from this picture here whether this injury is chronic or acute? Not necessarily. It could still be within a few weeks, right? Maybe they didn't get a lot of bruising, right? Maybe they didn't get a lot of commotions, right? But I will tell you that if it stays like that, do you think that's a permanent deformity? Yes, okay? Weakness of the adduction, we already talked about that. So any activity away from their body. That's what, by the way, that's what the patients are going to tell you. They're not going to use words like abduction and forward flexion, right? They're going to tell you they're having a hard time lifting their hand away from their body. That's what they're going to tell you. That's literally what they're going to say to you, okay? So you're going to document that. Chronic pain, yep. Chronic arm numbness, can you sustain an axillary nerve injury with these? Yes. Can you sustain a brachial plexus injury? We'll talk about later. Absolutely. Well, sometimes you got to look for other injuries too, okay? AC joint arthritis. Does that look like the joint was disrupted in that type 4 that there was a picture of? Yes. So with any of these, even if they have surgery, can they have early onset degenerative arthritis? Yes. So don't tell the patient they're going to be pain-free after surgery, because that's still not true. Okay? I will tell you. So non-operative, type 1 and 2, very reasonable. Type 3, and notice I went from 3 sticks to the number 3, just to clarify. Type 3, is based on what they do for a living, on their occupation, or on the demand of their activity level. Okay? Controversial? Sure. Let ortho decide. Okay? If you know someone's a pack bearer, right, so they're infantry and they got to carry a pack, and they have that walk-in deformity, are you going to make the call on surgery, no surgery? No, you're going to send them to ortho, because once that deformity gets fixed, right, and they get frozen in that position, is it a different surgery? Yes. So you send them fresh, as I like to say. Okay. So there it is, and it says right, some tissue modification, physical therapy. So here's a concept, I think I already mentioned about crutches, right? How long are you going to keep someone in a sling? Months? Weeks? Hours? Couple weeks is reasonable. So usually about a week or 2, right? That's reasonable, okay? But you want the patient to come out of it and do frequent exercises. Just because their AC joint, right, i.e. their shoulder is hurting, can they still move at the elbow? Can they still move at the wrist? Can they still move their fingers? Yes, so you can do that. Okay, the other thing you can do, pardon my support here. You tell the patient to support themselves. They come out of the sling. They just come downwards like I'm doing here, and they do small little pendulum swings, right? That's all you gotta do at first. And then they do larger ones, right? And then larger ones, see what I'm getting at? But never with their body away from them, right? So it shouldn't cause them pain, is what I'm saying. You teach them how to do it correctly, and that's why that's demonstrating there, the pendulum swings. Can you teach someone to do all this stuff in your office after you give them a prescription for maybe some PT and then go see ortho, see what's up? Yes, I just showed you how to do it. Very simple. It doesn't require them to do any actual active motion. They're literally just coming out of the sling, dropping their arm down close to their body, supported, right, and just doing little swings, right? So don't cause trauma that doesn't already exist. Okay, make sense? Again, operative type 3. An example of the book is young manual laborer. Manual is not a person; it means they're doing the labor, right, by hand. Okay. That's something. Didn't ask you that. So, that's a joke. Type 4 through 6, surgical repair, ligament reconstruction. Okay? See these awesome pictures of surgery, right? And it tells you that this is the absolute surgery for a type, this kind of surgery is for this, that kind of, no. You think it's that simple? Absolutely 100% not. I will tell you this, in orthopedics, we call this surgery the surgery that wants to fail. Okay? Surgery that wants to fail. Has anybody heard that before? No? Because say someone is an infantry soldier, right? And you do surgery on them, what are they going to want to get back to doing soon? Being badass, right? So they're going to want to put packs on. They're going to want to cause motion there, right? They're going to want to lift things heavy overhead. They're going to want to get up into the ready position, right? And then fire, and they're going to want to have supported, right? The 240. Right? 240 is awesome, right? All that kick, pushing backwards, posteriorly. Right? You're going to want to do all this crazy stuff, right? So there's a lot involved with these surgeries is what I'm saying. So we will oftentimes get a patient that comes in, and we'll tell them, say, the only time we're gonna do surgery on you is if you agree to the post-operative protocol. Because if you don't, the second surgery is never as good as the first. Does that make sense? So why do I tell you this? Why do I tell you anything? Because I want to tell you that you shouldn't be promising the patient anything when it comes to this surgery, right? When you send an ortho case, you just say, go see the surgery people. They'll let you know what they think is best. Don't promise them they're going to be pain-free. Don't promise them they're going to be the infantry soldier for 40 years, right? The next whatever of the army, right, or whatever. Okay? Don't promise them anything. Because I can tell you, these surgeries don't have the best success in certain patient populations. I just described some of them to you. Okay? What do you think all that's from? Excoriation, scratching potentially, adhesives. You know, sometimes they go to physical therapy, they don't want to do a bunch of taping and all this craziness. Okay, so again, you can have skin breakdown from, again, the taping, the sling. Stiffness from immobilization. I just told you how important it is for them to come out, move with the elbow, move with the wrist, move with the fingers, do the pendulum swings. You think stiffness is the enemy of orthopedics? I keep saying that, right? So we want to fight stiffness every chance we get. Okay? And then obviously AC joint arthritis is a bad outcome, right? But all patients that sustain the injuries will have it. Okay? Will have some level of early arthritis. Okay? So, but absolutely 100% knee surgery every single time is 4 or more, right? 4 or more is ortho. Okay? That's how they get this. See right.
Yeah. You could say that was
Is it a one-time? They are trying to change it. It's not like we're paying it.
No, I am a mental.
What if they do pizza?
Huh?
No, they bring pizza. I know salads. I know it's not perfect.
You got rice.
They try to people that actually I usually eat my lunch. I think it's good to learn like everything. That's why I'm always there. Whatever there's left of me, you never know.
months. And then you get all certified like and then after that you go to the aviation. You're just for the aviators. We have like special regulations. So of course it's just you learning regs and waivers and you have to do. It's not like you're flying. I think what you training but there is every 3 months of so they usually make their hours like so this slide is like 1 day a week. They'll fly to like a different place, have lunch, just fall back to sleep. That's just maintaining your business.
But I also, if you're in aviation, you don't get because you're in my regular line unit, you have a lot
I would like to tell you, I also like to tell you,
Oh, you're right.
I would like to tell you.
yeah, regular line unit. We don't get those. So it is an advantage.
Like, you'll teach, if you have a good BA, you'll teach like the flight for the most part, you're stuck in the clinic 10 days, treating aviators, and you're not going to see this.
Big point. That's why
I spent a lot of money in my career as a I kind of want to do some very easy. It's not hard on your body. It's one thing.
one day that I shadowed, she went to like start some exposure and experience.
That, I'm going to see you go retire once in your house. Just give people stuff.
Or you know, like there are nurse practitioners who can't get the SRP, you know, just ask them some questions, sign the paperwork.
Oh, yeah. What's crazy is the and all their classes is online.
There's a non-nutritive like now. I think my friend did. She did all her classes online at the University of Boston. So you need everything online. But past the whatever, it's been published. You don't get your paper published.
I saw you passed out during.
That's what my friend did. Yeah, I don't know how she did it. She was a nurse. Multi-years, she was a nurse practitioner. She used to do her preceptor and all that in Seattle. She did monthly class for her. She's a nurse practitioner. Multi-years, she worked in one of their urgent cares, and she recently took another job where she gives out educational insurance. I know. That's why I always. That's how
And you gotta go
down.
leave pain coming back. Are you trying to go to lunch?
What about
Body disdain as well. Yeah, so like,
Oh, I saw that. Like there's operator. Oh, we should put on a table, like. Like, yeah, water.
You know what I'm having for dinner? Whataburger, pizza. Huh? Thought it was drive-throughs.
No, I've been this semester. I haven't gone to the drive-thru. Worth asking.
Other than Taco Bell that we did, and then I went to like Whataburger maybe once.
I don't want to.
Yeah. I'm not sitting here away, by the way.
Sorry.
Who did it? Alright, so, the moment you've been waiting for. Brachial plexus injury. How in the world is this different than cervical radiculopathy? Well, I'll ask you this. You should already know that. Is your brachial plexus more distal than the cervical nerve roots? Yes. So that's how it's different. So therefore, the mechanisms are different, right? So with this, a patient will present with a mechanism of injury, right? So right off the bat, I will tell you, that's why they're called burners and stingers, right? Has anybody here had a burner or stinger before? No? Yeah. So we won't pass the mic to Fraser because he'll go on and on. But at the same time, we will understand that that these injuries have a story, right? So get the story. There's cervical spondylosis, right? Arthritis of the C-spine, degenerative disc disease of the C-spine, have trauma necessarily? No. But do things hurt? Yes. Hopefully in orthopedics you've learned that although it sounds like we're mean people, we really want to know the story because we really don't put as much value into the pain to get the actual diagnosis down, right? My dad used to say, my father was a police surgeon, right? So he used to say, does it hurt me to do this? Yes, Dad, it does. Does it hurt me to do that? I said, yes, Dad, it does. So he'd say, stop doing that. And that was his answer, right? So that sounds great. But anyways, so brachial plexus injury. So I changed this slide too. So if you look at the bottom, we're getting right to it. There's a link there, right? If you want to know everything you want to know about brachial plexus injuries, there's a link there. Go to it, read about it. But I will only test you what's on this slide. Because I will agree that although your textbook tends to kind of put these things into very specific categories as far as the mechanism, that there could be some variance. I get that, okay? So, but it says right there, a broad array of neurologic dysfunction, right, around the shoulder that results in momentary paresthesias to flail upper extremity, okay? So, very commonly, if someone sustains a helmet to the shoulder during a football game, will they tell you that they have numbness and tingling along the arm, down the arm, and that they're unable to lift their arm away from their body? Yes, that's what they're describing. Okay? But is there a story there? Yes. So if you just go ahead and look down here, it says burners or stingers, right? Transient brachial plexopathy, right? So transient, meaning it should get better. Okay? It should be fleeting, coming and going. Okay? And eventually not. That there's traction force, excuse me, or compression force. So you would agree then that the helmet to the shoulder can be more of a compressive force, right? And not a traction force. Okay? Good to go. Okay. So again, is this the compression being described here? Yes. Is this a distraction being described here? Yes. And then, can there be ipsilateral flexion and hyperextension? Yes. So could it also be like a whiplash type injury? So that's kind of your third one. The book doesn't really get into. Okay, so for testing purposes, just important to understand that it is going to be compressive or traction. Those are two of the bigger categories, but there can be more complications than that. But across the board, what nerve roots are involved? So you guys would agree that C5, C6, but the thing that differentiates this between C5 and C6 is that although they can't abduct their arm away from their body, and they can't extend their wrist, right? That there's a history and there's a mechanism of injury that would denote that there was a brachial plexus injury, and that this is not just strictly cervical radiculopathy. Correct? You all agree on that? Okay, because when it comes to pants, don't get it too twisted. Right? Right? Don't get them confused, because the history is going to tell you whether or not you should be thinking more about brachial plexopathy versus cervical radiculopathy, because there'll be a story involved with it or along with it. Okay? So don't miss that low-hanging fruit. Okay? Right? Okay. Good. Any questions about that? Okay. So brachial plexus, you guys have already started neuro, right? Not yet. Okay. So brachial plexopathy might even make more sense after you finish neuro, right? But I will tell you this, that when it comes to these preganglionic and postganglionic, you guys know what ganglia are, though, correct? So you remember this from just general A and B, right? General A and B, right? Yes? Okay. All right, because when we're talking about this, you need to know what the ganglia are to understand whether it's pre or postganglionic, right? But as a rule, preganglionic has a worse or better outcome.
Bad.
Poor? Yes, that's what I see. Okay. So poor. So preganglionic, poor, postganglionic, better prognosis, okay? And that just basically gets to this, okay? You see this stretch here? By the way, is this the ganglia here? Yes. Yes, that's the ganglia there, okay? That's kind of that bridge between pre and postganglionic. Okay, so if you see that stretch that's postganglionic, it's going to have a better prognosis. Okay, so do you think that that if somebody has a significant avulsion, as it shows here, where from the ganglia, the entire nerve tract, the axonal tract, right, gets stretched and detached from there, then they can have a significantly poor outcome? The answer is yes. That's all they're saying. That's it. Okay, you guys will get more into it when we get into neurology, right? But you guys got the little primer there, okay? But this is an important concept to understand, because I've seen this question asked, just like this. What has a better prognosis, pre or postganglionic? And then most people take the point out and they flip it, right? But you guys are experts and you'll remember this now. Okay? The rule of orthopedics is 50-50, 80-20. Okay? So clinical symptoms, well, do you think that when you ask the patient for their history, you're not only going to ask them about what sports they were playing, right? You're also going to ask them to describe what position their neck was in, what position their body part was in, right? If they were stretched, in which direction were they stretched? Were they stretched laterally or hyperextended? Does some of that terminology come into play here? Yes. See, the shoulder is depressed and the head and neck are tilted toward the opposite side. So that's what you're getting at. You're trying to get a better sense of what could have happened in the ganglia, whether it's pre or post ganglionic, okay? So that's what they're getting at there, okay? So upper and middle trunk, C5, 6, 7, that's what you're only going to see is that shoulder depression, lateral tilt. And then lower trunks, C8, T1, that's that stretch with the arm in abduction. So that would be the arm away from the body like this, correct? Yes? Okay, C8, T1. Okay. So another layer to add to your remembrance now. They have the arm stretched like that, and they have C8, T1. By the way, what does C8 do? Similar to your basketball analogy, right? So your ability to curl your fingers and spread your fingers. Those are different actually, right? One C7 and one C8. Right? Okay. Does T1 have a reflex? No, not unless you make one up. I don't know. I don't really know. Okay. So what is dermatomal? What? Neuralgia. So that means that the neural injury, this is neuralgia, not radiculopathy, correct? Dermatomal neuralgia means that those ganglia that are involved, right, from those cervical nerve roots, that they go in a certain distribution. Okay? When you guys get done with neuro, you will understand. Well, I think you might understand. Remember that there's a saying. Remember that saying I said yesterday to remember the wrist bones? Yeah. Anybody want to say it out loud while I'm being recorded? No? That's right. I went to Dr. DeBoer and said the thing. He said it to me. He rattled it off. He's like, that's still how I remember it. So trust me when I tell you, if you remember it that way, you'll never forget it. Okay? But, anyways, real Texans drink cold beer. That's the saying. Roots, trunks, etc. when it comes to brachial plexus. If you go and you look that up today, it is not testable. Let me repeat that. Roots, trunks, real Texas drink cold beer, I will not test you on it. I can't promise you it won't be tested on it in neurology. But if you understand how complicated the brachial plexus is, right, then you'll understand why I stick to this up here as far as what I'm going to kind of ask you to understand. Okay? This up here, these descriptions, right, these mechanisms, but that it can be more complicated than that because the brachial plexus is super complicated. Okay? It is, right? But for the most part, with these dermatomal neurologists, they're going to have that burning, searing pain, right? It's going to be described as a shoulder slash neck pain. They're going to have pain that radiates down its dermatome, usually a very distinct dermatome, okay? And then they're also going to have burners that last just seconds to minutes, maybe a little bit longer. But if they have symptoms that last longer than a few days or on into a few weeks, could that be an indication of more significant pathology? Yes, we'll talk about what you do with those patients. Okay. So, anybody, did you play football when you had the burn? Rugby. Okay. So when you got to the sideline, did somebody come and like test you out, ask you to move your neck around, all that stuff? No, they just didn't care about you. Oh, it was a club team. Okay, never mind. But if you're in a professional sports team, so like when I was at the Air Force Academy, we covered the football team, we covered the rugby team, we covered the soccer team. We were on the sideline, right? And wave the ball, I'm on the sideline, right? So when the person would come over, we'd ask them, where do you feel it? What do you feel? You know, do all these, you know, extend your wrist, flex your wrist, lift your arm away from the body, all those things, and make them do it, right? So it's the plexus injury, not a cervical spine injury, right? We saw the injury, we witnessed it, and then we try to see like how long their symptoms last. And based on how long their symptoms last, we determine what their ability to return to play is. Make sense? So it's going to be a little bit like that when you guys are talking to these patients, right? They come in and say that they were seen on the sideline. You're going to ask them, how long did you have symptoms? Were you cleared to return to play? Things like that. Okay? Here we go. A couple of nuggets. None of that's testable. Okay? But I just said that when you're talking about brachial plexus injuries, you want to make sure they don't have C-spine injuries, right? If somebody had a cervical plexus injury, say they took a helmet or they went head first, what I call the battering ram, right? Because some people are just headstrong, as my mom would say, right? And you have a concern for a C-spine injury, you're gonna work that up, right? You're gonna do significant neurologic testing, as we've been discussing. And if there's a concern for a C-spine injury, you're gonna put them in a C-collar, right? You're not gonna take them out of that C-collar until you clear it, regardless of how much burning, searing pain they have, their inability to extend the wrist, etc. You're gonna rule out the fractures and potentially the irreversible spinal cord injury that could occur if they have an unstable spinal column. Because we already know about that, right? We know about vertebral columns. Okay. So you're gonna look for concomitant injuries, okay? Clavicle, scapula, right? Humerus fractures, scapulothoracic dissociation. Okay. When it comes to scapulothoracic dissociation and scapular injuries, have you guys discussed in any other classes that when you see those two terms, you need to be concerned about significant other injuries? Never? Okay, you'll learn this in EMED, in trauma in senior year as well. But I want to introduce this topic to you, okay? Anytime you see a report or you see a scapular fracture on imaging, you need to look for more injuries. The amount of force that's involved to have a scapular injury is significant. Same thing with scapulothoracic. Do you think it takes a large amount of energy to dissociate, right? To remove the association between your scapula and your thoracic spine? A lot, right? So you need to look for concomitant injuries. It's what we call commonly in medicine distracting injuries, right? And these injuries that you should be looking for, they're called distracting injuries, but they shouldn't distract you from assessing the patients. It could just be that the patient has pain here, right? But then all of a sudden you see a scapular fracture on the report, scapular fracture, and you need to start doing other imaging. Make sense? That's it. We'll get more into it in senior year. Okay? So serratus anterior, serratus what? Anterior and rhomboids there. You guys know how to test that, right? How to have someone go against, right? And to make sure that you resist motion. Okay? Are those part of the rotator cuff stabilizers? No, it's not part of the rotator cuff, right? So that'll be something that is long term, right? You may see weakness in those distributions. Okay, that's all that's saying then, right? That's all it's saying. So that's not something you guys are going to see acutely necessarily. Because it's not easy to test. Okay? But if somebody has ongoing chronic pathology, bless you.
That's it, thank you.
So from an injury like this, could you see like progressive wasting or atrophy of certain musculature over time? What are the muscles? Yeah, there they are. That's what they're saying there. Okay? So upper trunk is more commonly upper or pre or post ganglion? Post. Okay, so we just added another layer to our knowledge base. And lower trunk is most commonly pre-ganglionic. Okay, so we just added another thing to our lexicon here. So when it comes to pre-ganglionic, we would agree that that's more significant, correct? All right, so let's put it all together. If you go back to this slide, then CAT1, is it sometimes more significant injury when the patient is in this position and they get stretched out and have a brachial plexus injury, and therefore it's pre-ganglionic? So that injury pattern should concern you. Okay? I've seen this injury pattern with special forces when they're doing hanging training. I'll leave it at that. They're hanging, right? And they're in this position, and there's a strong traction force. Right? Your brachial plexus gets stretched. Right? We have a high concern for that. Okay? So again, if you have someone that gets injured in this position and has lower trunk involvement, that tends to be more pre-ganglionic and can be more concerning. Good to go? We just put it all together, right? We're all good. We get this. This is easy. Okay, so brachial plexus imaging. Well, pretty common, right? Can you x-ray the brachial plexus? No. So the brachial plexus, you can't x-ray it, but you can x-ray the C-spine, correct? Right? So what you're not going to do, right, is you're not going to get flexion extension views. You're not literally going to go chin to chest or all the way back like this until after they've been cleared for their C-spine. That's all this slide is saying. That's it. We get back into the trauma again in that. Okay? But you want to rule out instability. We talked about instability when it comes to C-spine. Congenital abnormality, cervical stenosis, all those things. If you have a strong suspicion for neurologic involvement, do you think you're going to get an MRI? Yes. I'm going to add a twist here. If you get an MRI of the C-spine, is that an MRI of the brachial plexus? No. So an MRI of the brachial plexus is different than the MRI of the C-spine, of the cervical, right? Cervical MRI. So I tell you that because does orthopedics treat brachial plexus injuries? No, neuro does. Oh yeah. Okay. There you go. So if you're thinking to yourself, you got to get brachial plexus MRI, you're probably going to be talking to a neurosurgeon, correct? We do not operate. We like to say this, right? With the exception of the C-spine, right? Of the spine, right? We like to say orthopedics, we don't operate above the family. Okay. So soft tissue suspicion comes from here, brachial plexus, or spinal, right? We don't. That's not us. Okay. Good to go. So when you're talking about outcomes, obviously all this is bad, right? I'm not going to read this to you. What's the worst thing? Paralysis, right? So again, if you don't assess them appropriately and you cause further injury, further compression, further traction, further compression, whatever have you, right? You can cause permanent paralysis. Permanent, not reversible. Okay? When this says amputation, does that mean you take their head off? No, that doesn't. That will not sustain life. That means that they may have to lose the extremity. Okay? Just to be clear. That was a real question. So treatment, NSAIDs, rights, activity modifications, splinting. What do we mean by splinting? Brace collar. Okay, if it was a compression injury, you see this little device here? Okay, this little device there. What do you think that does? Traction, right? So you can put that on somebody carefully. You can set the dial. You can increase the dial, and you can cause very slow but gentle traction. Okay, and then you can take it away. Okay, so sometimes that's done. Okay? That's showing a very specialized collar, obviously. Do you ever want to do cervical manipulation? The answer is still no. Okay, so never cervical manipulation. I don't hate chiropractors. Okay, and when it comes to when you return to play, someone on the sideline who's trained, right, or someone like me maybe, or someone that's a specialist, tells them that they already have a normal exam and they can return to play. That's the answer there. Okay, this is not one of those softballs where you're like, I think it'll be fine. Don't be the it's probably fine person, right? If you have a concern for this patient, you tell them, say, I'm going to keep you on this collar until you see neurosurgery again, neurology, what have you. Okay, makes sense? Do we sometimes see these brachial plexus injuries as part of combat downrange injuries? 100%. You see these all the time. People are wearing brain buckets, right? They're wearing that thing on their head, right? So if they get taken in a certain direction, you want to keep going in that direction, right? So sometimes just that force alone is enough to cause traction or compression. Okay? Just, so it doesn't have to be like a full body on the directed to the neck region. Okay? So, anyways, operative severe cases, obviously if it's neurologic deficits, you got to get to it. Surgical repair reconstruction, again, not me, not orthopedics. That is neurosurgery. They operate the brachial plexus. Okay? Don't get tripped up by that on pants, please. If you're talking about a brachial plexus concern, choose the answer that says you MRI the brachial plexus. If you get a cervical MRI, useless. I'm going to tell you what you need to know. Ready to go? It's a plexus injury. Okay? If there's a question, guys, let's get back to this question on the test. If there's a question as to whether it's a brachial plexus injury, cervical radiculopathy injury, or peripheral neuropathy, what's the study you do? EMG nerve conduction study. Okay? You still got it right. That's good. Right. So when are you going to refer? Well, obviously bad situation. And your exams keep getting worse. Right? Serial, as in S-E-R-I-A-L, not C-E-R-E-A-L. Right? You're doing multiple neurologic assessments and they're getting worse. Refer. They have persistent symptoms. Refer. They have recurrent or bilateral symptoms and other injuries. We talked about that. You refer. Okay? That's it. Any confusion between brachial plexus, and cervical radiculopathy. If there is tomorrow, let me know. We're going to review regardless, right? All right, frozen shoulder. I hate this term, but it does tell you something about the pathology. But frozen shoulder is very vague, right? It doesn't really tell you the pathology. So this is also called adhesive capsulitis. Okay? And adhesive capsulitis is actually more helpful. Because when you're explaining it to the patient, adhesive capsulitis helps you explain it to the patient. We'll get into it. Okay? AKA adhesive capsulitis. So is there a capsule on your shoulder joint? Yes, correct. And so when the shoulder joint gets thick and inflamed, like this picture shows here, you think it says mobile? No. So therefore, if you have that adhesion, those adhesions in the capsule, does it result in decreased range of motion? Yes. So that's how you explain it to your patient. It's an idiopathic. If you say to your patient, sir, ma'am, you have an idiopathic loss of your shoulder range of motion, do you think you're going to have any idea what that means? No, but if you just describe it like I just described it, A, you remember it, B, you'll actually might understand that. Okay? So what kind of, again, motions are they going to have decreased? Well, generally, you can think of it as activity away from their body, but very commonly, it's going to be external rotation. Okay? So is this something when you guys are doing your physical exams, are you going to ask them to do it? I'll give you three choices. Are you going to ask them to do it and then you do it as well? Just them do it, or just you do it? First off, right? Good. And we'll get into why. Okay, does this condition very commonly live with other conditions? Yes. What are those conditions? Diabetes, the sugars. Okay, so if you see somebody that has, like the vignette says, it is a 45-year-old female with a history of uncontrolled diabetes who's now reporting shoulder pain and pain at the end. Right? So they're having difficulty extending their arm away from their body or lifting something up heavy overhead. What is your number one diagnosis? Frozen shoulder. Could it be other things? Yes. You can develop a differential diagnosis, so you can impress your plank force instructors. So of course it could be other things. But you need to think this. Okay? Make sense? Diabetics, more refractory treatment. 40 to 50% have bilateral involvement. Does that mean that most, half, let's say, right? Diabetics could have it in one shoulder and then eventually develop it in the other shoulder? Yes. So do you think as part of your history taking, you might ask them, I think you have adhesive capsulitis, ma'am, or sir, right? I'll judge. But then you might want to ask them, have you ever had this, let's say, in another shoulder? And they say yes, because you asked them. And only because you asked them? Yes. Does it give you an indication to you being able to ask them how it was treated? And how long it took them to be treated for it? How long it took for it to resolve? All that will come up here soon, okay? So do you guys understand this picture here? Okay? You good with this picture? All right, what do you think this is a picture up here? All right, so that's inside. That's sticking a camera in there. Someone's doing the Lord's work, right? Put a camera in there, take a look and see what. Do you think that tissue looks angry? Is that red normal? It's supposed to be like a healthy light pink color. Kind of like the gentleman back there, right? Healthy light pink color. Right? So but not this angry red. Okay? Shouldn't look like that. Okay? So, are there stages in frozen shoulder? Is it as simple as saying it's either frozen or not frozen? No. What are those descriptors? Freezing. It's getting worse. It's getting frozen. Okay? This is where frozen shoulder might help. Right? But they can have pain, but more importantly, right? Because pain is not supposed to distract you from making a diagnosis. But more importantly, they're having decreased range of motion. So that's what you're asking the patient. And that's what you're charting and assessing as you're seeing them back. Okay? Thawing means that now they've gone beyond the freezing, and now things are hopefully returning to a level where they don't have as much decreased range of motion. Slow and steady improvement is the key here, okay? Slow and steady, but still prolonged. I want everybody in your mind to stop studying farm and look at that bottom line there. How long does it take for frozen shoulder to get better? 6 months to 2 years, right? So if you send them to orthopedics because they've been frozen for a month and you just think they're not getting any better, do you think that's reasonable? No. And I'll teach you some stuff you can do at the primary care level if you're comfortable, right, to help them along in the right direction. Okay? Makes sense? So we would agree 6 months to 2 years. So you see this continuum we have here? Right? So they go from inflammation to freezing to frozen to thawing, right? And again, if they're diabetics, does it recur? Yes. Does it sometimes move on to the other shoulder? Yes. Okay. Does diabetes put a patient into pro-inflammatory condition? Does smoking also do that? Okay, so smoker diabetics, not my favorite patients in orthopedics. Okay, all right. Especially external rotation, I already said it. Passive range of motion is really what you want to get to, right? If you, again, I get back to this principle, and people tell me, like, why do you keep saying this? It's like a very intuitive statement. But if someone hurts, like, and you tell them to do something, you think they're going to give it maximum effort and really be able to tell you what their range of motion is? No. So in this case, especially, you're going to have to do it yourself. Okay? So diffuse shoulder pain, sometimes we'll say it's tenderness at the deltoid insertion. There's the word insertion, right? But I'm just telling you. It's basically just saying right about here, right? So they may say they have pain here, anterior shoulder cuff. That's the way we describe it, the anterior shoulder. Okay, but it also radiates over here to the deltoid region, so the lateral deltoid region. That's all they're saying there. Okay? That's all they're saying. Right? And then therefore they have decreased external rotation. Does external rotation of the shoulder in some way, shape, or form require some abduction as well? That makes sense. What's the abduction of the shoulder? The deltoid. Good to go? We're all good? Your knowledge of anatomy is powerful. You guys memorize all these normal range of motions, right? Because that is how you're going to know what normal and abnormal is. Okay? I can't teach you that to you. Normal range of motion are static numbers. Okay? So how do you think you're going to be able to tell if over that 6 months to 2 years the patient is improving or worsening? You're going to get, and this is a crude example, right? Everybody knows what a goniometer is? It's this little thing here to measure. This is actually for a finger. Okay? I've got to make over the balancing and scale ones for a shoulder. Okay? I mean, appropriate one. I mean, far away. Okay? So, but you're basically going to go put the goniometer sometimes, or you'll just understand that at some point, if you understand what 90 degrees is, right? And you understand what 35 degrees is, it's your comfort level. So you can use a goniometer if you need to. Especially if the improvement is just a matter of degrees, then maybe a goniometer can help you. Well, they improved 2 degrees. They improved 5 degrees. You see what I'm getting at? So, but you don't always need that. Okay? Good to go? All right. So shoulder imaging, of course, you see the pathology here, right? Everybody sees it. You see that white area here? Is that the capsule here? Right, that's the inferior portion of the capsule. That's usually where people are going to get that thickening and those adhesions. Okay, everybody, even if you don't see it, you would agree that this area here looks kind of normal. A little bit of white here, a lot of white here, and oh my God, white there. Okay, so when you get an MRI and you get this view, this is a corner view, right? And you're looking through there, you may actually start seeing these changes in the future for yourself. I will not ask you this, okay? But why would you get imaging? Again, because you want to rule out other pathology. Can a space-occupying mass cause pain in the shoulder? Absolutely. So if the clinical picture is unclear, especially, you're going to get radiographs. Okay? Good to go. Try to let you guys out here a little bit. We already talked about MRIs for the shoulder. Anytime it's in the glenohumeral joint and you're trying to decide whether it's labral involvement, rotator cuff involvement versus, let's say, the pouch, in this case, the inferior pouch, would it be useful to use an MRI with contrast, otherwise known as MRI arthrogram? Yes. Okay, everybody understands that the MRI arthrogram is injected, correct, into the shoulder joint? This is different than the other ones where the patient gets an IV, okay? So they'll actually inject that into there and see where the fluid goes, and see what it looks like when they inject it. Good to go? Is this uncomfortable? Yes, so again, we order these when indicated though, okay? All right, adverse outcomes disease, residual pain, stiffness, sure, it's called frozen freaking shoulder. If you don't get the range of motion back, they're gonna be stiff. Make sense? So that's what you're trying to avoid, okay? So treatment, all right, non-operative. What is the percentage of people that improve with non-operative treatment?
80 to 85.
Very high, right? 80 to 85%, okay? So you as PCMs, guys, if you see somebody, right, old lady boo, okay, she's 45 years old, she's non-controlled diabetic, she likes to party, she likes to drink Aquafina and scotch, right? And she's having decreased, I just saw it, that's what I used that. So if you send her to physical therapy early, do you think she would have a better prognosis than if you send her to physical therapy late? If you have decreased external rotational physical exam and a strong suspicion for adhesive capsulitis? Yes. So the timing of it is important. The earlier you get it moving, remember motion is lotion, and the enemy of motion is stiffness. Okay? Moist, gentle stretching program. I'm not going to accentuate the moist part. That's weird. But the gentle stretching is the one I want to accentuate. If someone's stuck in a frozen position where they can't get above a certain level, and you just rip right through that, do you think that not only cause pain, but cause fractures and tearing of muscles and tendons? Absolutely. So the gentle stretching is terrible. Okay? All right. So intra-articular steroid injections. Have I talked about steroids much at all yet, other than just talk about generalities? Not really, right? So I would tell you though, for the injections for this, when it comes to doing these injections, do we inject everybody 100% across the board? That's a number 2 up there, right? So I told you whenever I write number 2, I need to do number 1 first. I'll take that 2 literal, okay? I'll do number 1 and number 2 right now, right? But I'm saying number 2 is not everybody, okay? What that means is you have been following a patient out, they're not improving, you got your goniometer out, you're getting your measurements, they've been going to physical therapy, you confirm they're actually going there, and you demonstrate their home exercise, sir. You know that they're complying with therapy and they're not improving, then you consider doing an intra-articular steroid injection. Because you think if we injected everybody, then they would all just go away and it wouldn't hurt anymore? Well, the answer is actually yes, right? Because you inject a steroid, it doesn't hurt anymore, right? But does that mean that they necessarily get their range of motion back? No. The reason we inject them with the steroids, if we're concerned about their progression, is because A, it stops that inflammation. It stops that adhesive nature of the inflammation on top. And it gives them a decreased inflammation, therefore you get decreased pain. Yes. So then they can push a little bit harder than physical therapy. Right? We all know maybe we've been patients before, right? And we got referred to physical therapy, but my knee hurts so much I can't do anything in therapy. So then you get sent back to your PCM because the physical therapist, I can't do anything with this person. They won't do anything. Everything hurts. They won't do any of the exercises. You see what I'm getting at with this? It's a concept, right? So to kind of go back to it, conservative care, moist, heat, gentle stretching, all patients. The only patients you're going to consider injections for are the ones that are not showing improvement or they've plateaued. They've hit a block in their progression, right? So instead of going from this they're stuck in this frozen stage. Does that make sense? They're not going into a thawing stage, right? And how do you know that? Because the patient's not getting an improvement in the range of motion. Are you good with that? Okay. Let's slow down to that slide. There are a lot of questions about that. All right. So when you're talking about surgery, right? We don't like these patients on orthopedics. Not because they're diabetics, not because they're smokers, not because they like scotch and water. Right? We all like those things, except for diabetes. Right? But the thing about it is that there's really no good surgery for this. Right? It's not like a broken bone. It's not like a rotator cuff tear. What do you think we have to do with that adhesive capsule? We go in there and start tearing it apart. Right? We break up those adhesions. A lot of times we go in there and muck things up. Right? We might have to bag perfectly good structures. Okay? In order to release it. So it's not really a fun surgery for orthopedics, but we'll do it if we need to. Well, what is the percentage of people that actually improve without surgery? 80 to 85%. So you see what I'm getting at, right? How many of these have I seen in a 20-plus year career? 2. 2 and 20. So not very common. Okay? So it's not great surgery. So we will literally keep sending to physical therapy as long as you're compliant. We'll do injections, no more than how many?
3.
Right? But you will try to avoid the surgery because then could they potentially have shoulder instability afterwards because we have to release a bunch of different things and make the shoulder unstable now, right? Right? And is surgery risky with uncontrolled diabetic, smokers, partiers? Right? Alcoholics? Yes? I know I'm judging a lot today. So adverse outcomes of treatment, like I said, tendon tears, humerus fractures, aggressive physical therapy. If physical therapy breaks them, let them be the ones that break them, not you, right? Don't be doing a bunch of craziness. But if you're going to put a physical therapy referral in, what is the words you're going to use? Moist, warm, and gentle stretches, correct? All right, good. All right. Don't be afraid to tell the physical therapist what to do. We talked about this before, right? No disrespect to physical therapists. Sometimes you just need to tell them what to do. Otherwise, they get crazy, right? Especially in the army. So when are you going to refer them? So you've been playing with them in clinic, right? You've been seeing them back. You've been noticing some improvement, but they just don't quite clear that hump in 3 months, right? And you're concerned about them. You send them to us. Okay? So does that say some improvement, or does that say no improvement? Okay, good. Just want to make sure. All right. I'm going to let you guys go. You cool with that? Yeah.
Sure. The answer is yes.
Have a good afternoon.
So it's not.
All right.
I gotta help.